Hi everyone. Let's start with the next module from respiratory system students. This is the last module, that is the lung tumors, right? Remember students, this is a very important topic for all MCQ exams because every year you will see either AIMS or NEET or JIPMER or any of the Central Institute exams. They give you a question on this topic. Especially students, be very careful in understanding the images from this chapter, from this module, because these images are also asked in the exams, right? Let us start our journey of lung tumors, right? Let us start our journey of lung tumors. Now, before I start with the various lung tumor students, let us do a few MCQs or one-liners, right? If the examiners ask you, which is the most common lung tumor? Which is the most common tumor of the lung? The answer is metastasis. And from which place does the metastasis usually come to the lung? The most common cancer which metastasizes to the lung, the answer is breast, right? So breast is the primary. In fact, lung is the most common organ to which various metastasis occurs, right? So two MCQs, the most common lung tumor, METs, most common cancer which goes to the lung, answer is breast cancer, right? Now, let us start, then students, if they ask you most common primary lung tumor, which is the most common primary lung tumor? The answer is going to be a pulmonary hamartoma. It is going to be a pulmonary hamartoma. The most common primary lung tumor is going to be a pulmonary hamartoma, right? Few words about pulmonary hamartoma, students, before I proceed further. Pulmonary hamartoma is a solitary 3 to 4 centimeter well circumscribed lesion. 3 to 4 centimeter well circumscribed lesion, right? Remember students, you will study this in radiology that on X-ray it produces coin-shaped lesions. Another MCQ, and there can, in a clinico-pathologic question, a coin-shaped lesion can be a clue to the diagnosis of pulmonary hamartoma, which is the most common primary lung tumor, most common benign lung tumor, right? And it is basically a well circumscribed, encapsulated 3 to 4 centimeter lesion, right? And what is a hamartoma? Remember in the basics of neoplasms, I told you what is a hamartoma? It is an abnormal proliferation of cells. Abnormal proliferation of cells. So when I see the histopathology on microscopy, you can see connective tissue elements. On microscopy, I can see connective tissue elements, I can see epithelium, right? And here another thing which you should know, which is the most common connective tissue which you see in a pulmonary hamartoma? Answer is cartilage, correct? So most common connective tissue in a pulmonary hamartoma is cartilage, correct? That's an MCQ. So these are a few things which you need to know about a pulmonary hamartoma. Its image I will just show you, although it is not asked in the exams, but I'll just show you the image, students. This is the image of a hamartoma. Now I tell you that this is a respiratory system. This is from a lesion from the lung. Can you see something like this in a lung lesion? What is this, students? This is actually cartilage. Will you see something like this? No. Will I see cartilage in lung? No. Right? In the lung tumor, will I see cartilage? No. So the presence of this cartilage indicates that this is a pulmonary hamartoma, correct? So This is the image. This is not usually asked in the exam, but just to understand the concept and the tumor, I'm just telling you that this is the pulmonary hematoma. Correct? Yeah. So after pulmonary hematoma, which is a benign tumor, let us start with the classification of lung cancer, right? The classification of lung cancers. Now, all of you know that lung cancers can be of three kinds, students. They've been divided into three categories. One is called as a small cell lung cancer. A small cell lung cancer, right? Another one is called as a large cell lung cancer. Small cell lung cancer. Then we have a large cell lung cancer, and the third category is called as a non-small cell lung cancer. A non-small cell lung cancer. So we have a small cell lung cancer, non-small cell lung cancer, and a large cell lung cancer. The non-small cell variety is further subdivided into two types. They are of two kinds, students. Squamous cell carcinoma of lung, right? Squamous cell carcinoma of lung. And the second is the adenocarcinoma of lung. Squamous cell carcinoma of lung and the adenocarcinoma of lung, right? These are the two kinds of non-small cell lung cancer. Here, what we have to do? We have to discuss all these cancers one by one, right? Okay, now let us start with the squamous cell carcinoma of lung. Squamous cell carcinoma of lung, also called as SCC, right? Also called as SCC. All the points which I'll be discussing with you now are potential exam questions, and in a clinico-pathologic question, they can be asked as clues, right? First point is male, much more common as compared to females, right? Next point is smoking associated. You know, students, Robin say that 80% of lung cancers are associated with cigarette smoking. Even passive smoking or second-hand smoke can be very dangerous, correct? So this type of lung cancer occurs in smokers, right? Centrally located, right? So it is present in the center of the lung, right? Sometimes in a clinico-pathologic question, you can be given a clue whether the tumor is central or the tumor is peripheral in location, correct? This is centrally located. It can sometimes produce cavitatory lesions. It can produce cavitatory lesions. Also, it can present with a intrabronchial mass. There can be a bronchial mass which can produce obstruction. Intrabronchial mass which can produce obstruction, correct? Then students, I directly come to the pathogenesis, which is also very important. What does the genetic mutation involved in squamous cell cancer? Very commonly asked, the genetic mutation, right? So it can be due to mutation in P53, RB tumor suppressor genes, right? Then there can be CDKN2A gene mutation, right? Or loss of chromosome 3p, 9p or 17p. Loss of chromosome 3p, 17p or 9p, correct? So this is the genetics behind squamous cell cancer. Now let's revise the important points once again. Males more common, smoking associated, centrally located, cavitatory lesions, can produce obstruction, What is the genetics? What are the genetic features? There can be mutation of RB and P53, which are tumor suppressor genes, CDKN2A, or loss of chromosome 3p, 9p, and 17p, right? Now, students, these lung cancers are very commonly associated with paraneoplastic syndromes, right? Which paraneoplastic syndrome is very commonly associated with squamous cell cancer? So, the paraneoplastic syndrome associated with squamous cell cancer is hypercalcemia. It is hypercalcemia due to parathyroid hormone related peptide, due to PTHRP. Very, very important. The others are usually present in small cell lung cancer. The paraneoplastic syndrome, which is present in squamous cell cancer of the lung, is hypercalcemia, which is due to parathyroid hormone related peptide, right? Correct. So this is the paraneoplastic syndrome associated. Next, another thing which is given in Robbins is the precursor lesion. The precursor lesion for squamous cell cancer, students, is called as squamous dysplasia or carcinoma in situ. Either dysplastic squamous cells can be there or carcinoma in situ. What is carcinoma in situ? You all know the basics of neoplasia. In situ cancer, basement membrane is intact. Invasive cancer, the basement membrane gets invaded. Tumor cells cross the basement membrane and infiltrates the stroma, correct? So these two, squamous dysplasia and carcinoma in situ, are the precursor lesions for squamous cell carcinoma of lung, right? What do we see on microscopy, students? That's a very important point. Remember, squamous cell carcinoma anywhere in the body, whether it is esophagus or lung or oral cavity, anywhere in the body will show this histopathology. What do you see on histopathology? One, I see desmosomes. Desmosomes. What are desmosomes? You know, if these are two squamous cells, these are squamous cells which are there, desmosomes are basically intercellular connections, right? When you see the slide on high power, you start seeing these desmosomes. It's a very, very, difficult finding to find. So at your level, you just need to know the name that in squamous cell carcinoma, we start seeing these tight junctions between squamous cells, which are called as desmosomes. The important point here, which you should know for any of the SCCs, is the presence of keratin pearls, the presence of keratin pearls. What are keratin pearls? You know, these squamous cells produce keratin. Now here, the squamous cells start producing excess of keratin, which is pink in color, and sometimes it resembles as, sometimes it looks like pearly features, it looks like pearls, so they are called as keratin pearls. For example, let us see this image, students. Can you appreciate these pearl-like structures? Pinkish, right? Here also you can see. They look like pearls which we see on the beach, right? You all know that pathologists are very fond of imagination. So when I see this slide, I start imagining pearl, the sheens of a pearl. The pink color starts coming like this. See here, you have excess keratin here, pinkish in color. So what are these? These are basically keratin pearls. Where will you see keratin pearls? Again, revision. You will see keratin pearls in squamous cell cancer anywhere in the body. But don't think that keratin pearl will be present in all SCCs, right? So basically, squamous cell cancer is of three types, students. It can be well-differentiated squamous cell cancer, it can be moderately differentiated SCC, or it can be poorly differentiated squamous cell cancer, right? When a person has well-differentiated HCC, you see these beautiful pearls. Like in these two images, I am seeing these pearls. So this is well-differentiated SCC, right? when a person has got moderately differentiated SCC, you don't see such beautiful spurs. What we see is individual cell keratinization. That means you will see excess keratin, definitely. I will see excess of keratin, but I will not see keratin pearls, right? And individual cells will produce excess keratin, correct? In poorly differentiated, you do not see keratin, no keratin, right? So my question to all of you is that if I don't see keratin, how will I diagnose that this is squamous cell cancer? What you will do in poorly differentiated SCC, you all know I have told it to you multiple times that we put immunohistochemical markers for poorly differentiated cancers or tumors. So what are the IHC markers for SCC? So what are the immunohistochemical markers for diagnosis of SCC? This is a very potential question these days, students. There are 3 markers which we can use for any squamous cell carcinoma anywhere in the body. One is cytokeratin. Remember when I gave you the table of immunohistochemical markers, I told you that CK or cytokeratin is a marker for any epithelial malignancy. So when I apply CK, I know that this is a epithelial malignancy. This is not a mesenchymal or a connective tissue malignancy, correct? Other markers which I can use are P63 and P40. P63 and P40. These are the 3 markers for SCC. Remember, P40 which is there, P40, this is the most sensitive and specific marker for SCC of lung. P40 is the most sensitive and specific marker for lung squamous cell carcinoma, correct? These are the important points regarding squamous cell carcinoma of lung. At the end of all 4 lung cancers, I'll give you a table, a gist of how to differentiate in between all of them. So don't worry, we will discuss all these points again, right? So I hope the images are also clear. Another image, students, of SCC, we have already discussed. This is keratin, right? This which we see is keratin, correct? Let's move to the next type of lung cancer, students, that is called as adenocarcinoma of lung. Adenocarcinoma of lung. Now, this is actually the most common lung cancer overall, right? So, overall, which is the most common lung cancer? Adenocarcinoma. Usually women, right? Usually women, usually non-smokers, right? It has been seen that the patient is a non-smoker, the patient is a woman. That does not mean that women do not smoke. In fact, the incidence of women smoking these days has increased exponentially, right? That is why the incidence of lung cancer is increasing exponentially amongst women also, correct? So it is usually seen in women, it is usually seen in non-smokers. It is peripherally located. So till now you will see that most of the points which I have told you, they are opposite to squamous cell carcinoma. That was men, this is women. That was centrally located, this is peripherally located. That had a history of smoking mostly. This usually occurs in non-smokers, correct? So these are 4 important points. Then, what is the paraneoplastic syndrome? So migratory thrombophlebitis. Which paraneoplastic syndrome is associated with adenocarcinoma of lung? Answer is migratory thrombophlebitis. Again, very important point. Then I come to the genetics. The genetics, again, very, very important, very frequently asked in the exam. Which genes are implicated in the pathogenesis? So they say there can be a mutation in EGFR, ALK, MET, RET, right, or KRAS gene mutation, KRAS, right? These are the genes which can be mutated in adenocarcinoma, EGFR, ALK, MET, RET, or KRAS, right? Now we come to the precursor lesions. Precursor lesions. What were the precursor lesions for squamous cell cancer? We already did. The precursor lesions for squamous cell cancer were squamous dysplasia and carcinoma in situ. Here we have two precursor lesions which are important, students. One is called as atypical adenomatous hyperplasia. Atypical adenomatous hyperplasia, or AAH, while the other is called as adenocarcinoma in situ, which was earlier called as bronchoalveolar cancer. You must have heard of this term, bronchoalveolar cancer. Now this entity, bronchoalveolar carcinoma, is called as adenocarcinoma in situ, right? So these are the precursor lesions of this adenocarcinoma of lung, right? So now I'll tell you some important points about both these entities. What is atypical adenomatous hyperplasia? So atypical adenomatous hyperplasia, students, the lesion is less than equal to 5 millimeter, right? And what happens in AAH? There are dysplastic pneumocytes. Dysplastic pneumocytes which line the epithelium, which line the alveolar lining actually, correct? Whereas when I see adenocarcinoma in situ, it is also known as bronchoalveolar carcinoma. Also known as bronchoalveolar carcinoma, right? Adenocarcinoma in situ. Then the lesion is less than 3 centimeters. And what happens in this lesion? The tumor cells grow along the bronchoalveolar lining. The tumor cells grow along the bronchoalveolar lining, along the bronchoalveolar lining. So suppose, students, this is the bronchoalveolar lining. My tumor cells are growing like this, right? When the tumor cells grow like this, what it looks like, you know, pathology, all about imagination. Does it look like that butterflies are sitting on a fence, right? That is why this pattern is called as butterflies on a fence. Let us see an actual image so that you can imagine. This is the image of a bronchoalveolar carcinoma. Can you see these beautiful cells? This is the bronchoalveolar lining, and tumor cells are lining this bronchoalveolar lining, right? So what it looks like butterflies on a fence. That is why it is called as butterflies on a fence. Another name for this is a filigree pattern. Another name for this is a lepidic pattern. So this is called as butterflies on a fence, or a filigree pattern, or a lepidic pattern. This is seen in which one? It is seen in bronchoalveolar carcinoma or adenocarcinoma in situ. Correct? There is more dysplasia as compared to atypical adenomatous hyperplasia. It can lead to the development of adenocarcinoma of lung. Right? What is so these are the two precursor lesions which you need to know of, students, for adenocarcinoma. Okay, so now let us come to the microscopy of adenocarcinoma of lung. When a pathologist gets the slide, what do you see on the slide? The microscopy. Adeno means gland, right? In simple terms, adeno means gland. So in adenocarcinoma, anywhere in the body, students, whether it is stomach, or whether it is colon, or whether it is lung, you will see, what you will see is, we will see glands which are lined by malignant cells, not so good cells. The glands are lined by malignant cells. So suppose this is the slide, students. What will I see? I'll see this glandular structure. That is why it is called as adenocarcinoma. And these are lined by dysplastic cells, very, very abnormal cells with high NC ratio, hyperchromatic nuclei, prominent nuclei, right? So these are glands lined by malignant cells, correct? The pattern can be any pattern, acinar pattern, trabecular pattern, any pattern can be there, but this is what I see, right? For example, in this image, can you appreciate these glandular structures which are there like this or this, right? And the cells which are lining these glands, the cells are not normal because these cells are hyperchromative. They have high NC ratio, prominent nuclei. Remember in the neoplasia chapter when I was teaching you anaplasia, I told you how do you define a malignant cell? What you see, they are pleomorphic cells. What is pleomorphism? Variation in size and shape of cells with high NC ratio, hyperchromatic nuclei, prominent nucleoli, loss of polarity, right? So these glands are also lined by such kind of cells. So this is basically adenocarcinoma. Anywhere in the body, whether it is GIT or lung, you will see such a picture. This is also well differentiated, moderately differentiated or poorly differentiated. In well differentiated, the glandular structures are much more well defined. In moderately, they are lesser defined. In poorly, you might not see any glands, right? In poorly differentiated adenocarcinoma, if I'm not seeing any glands, what will you do? Again, I'm repeating, you will do immunohistochemical markers, right? A pathologist will do IHC marker. Which IHC marker is important? Very, very important take home message and exam point. Which IHC marker is important for adenocarcinoma of lung? Answer is TTF1, thyroid transcription factor 1 or napsin A, right? So in the MCQ exams, if you're solving a clinico-pathologic question, so the next lung cancer is small cell carcinoma of lung, right? Now, what are the important points regarding small cell cancer? Again, it has the strongest association with smoking, right? It has the strongest association with cigarette smoking. Remember, strongest association, correct? So, two lung cancers which are smoking associated till now, small cell lung cancer, squamous cell lung cancer, correct? Then males more common as compared to females, just like squamous cell cancer. Then centrally located, just like SCC, this is also centrally located, but because it is a highly aggressive tumor, it can grow peripherally also. It can grow peripherally also, correct? Then it has the worst prognosis. Which lung cancer has got the worst prognosis? Answer is small cell carcinoma of lung, right? So usually students, what we see is when I see the patients, what I see is when the patient comes to me, the tumor has already metastasized to brain and to the other sides. That is why we usually do not do surgical resection. What is important for small cell cancer is it is highly chemosensitive. It is very chemosensitive. Correct? Then it produces maximum paraneoplastic syndrome. Overall in the body, students, if they ask you which tumor, which cancer produces maximum paraneoplastic syndrome, answer is small cell lung cancer. It produces maximum paraneoplastic syndrome. For example, which ones? Cushing syndrome. Cushing syndrome. Then SIADH, syndrome of inappropriate ADH secretion, SIADH, right? SIADH is in fact the most common PNS associated with small cell lung cancer. Remember, right? SIADH. Then students, next, genetics. What is the genetics involved? You know, the patient can have P53 gene mutation or RB gene mutation, or a very common oncogene which can be affected is LMYC. LMYC. Remember, when I was teaching you neoplasia, I was telling you MYC is an oncogene, and MYC is of three types, students: LMYC, NMYC, CMYC. All three are MCQs. L for LMYC, L for lung cancer. So LMYC amplification leads to small cell carcinoma of lung. N for NMYC, N for neuroblastoma. NMYC amplification leads to neuroblastoma. CMYC leads to Burkitt's lymphoma. CMYC problem or amplification leads to Burkitt's lymphoma. All three are MCQs. Please correlate whatever we study in systemic pathology with your clinical subjects and with your general pathology. Correct? So what is the genetics involved? LMIC, which is very important. Then, very, very important, students, what do we see on microscopy? When a pathologist gets a slide, what do I see on microscopy? So one thing which I see is small cells. That is why it is called a small cell cancer. So I see small cells. In fact, these cells are so small that their diameter is 3 times lesser than that of a small lymphocyte. Very, very small cells. And they have got scanty cytoplasm. Scanty cytoplasm, correct? There is a hyperchromatic nucleus. Small cells, scanty cytoplasm, hyperchromatic nuclei, right? Then a very important property which these cells show is called as nuclear molding. What I see is nuclear molding, right? What is molding? Suppose these are two nuclei and they are of different shapes, right? 1 nuclei, 2 nuclei, 3 nuclei. So they will fit into each other. They will mold into each other like a jigsaw puzzle, right? Nuclei will mold into each other. That is called as nuclear molding. And another thing which you see is necrosis. Another thing which I see on the slide is necrosis. Correct? 4 important points. Let us see an image so that it's very, very clear to all of you. See in this image, students, can you appreciate these cells? They are small. They have scanty cytoplasm. I can't see any cytoplasm. And they are dark blue. They are very hyperchromatic cells. Correct? They are dark blue. And at certain areas like this here or here, can we appreciate that they are fitting into each other's shapes, right? This phenomena is called as nuclear molding. So we see small cells, scanty cytoplasm, hyperchromatic nuclei and nuclear molding along with areas of necrosis, right? Another property which we see is something which is called as a azopody effect. Very important, another property which I see is called as azopody effect. What is a azopody effect? Sometimes you can get a direct MCQ that azopody effect is seen in. Answer is small cell carcinoma of lung. What is a azopody effect and why will you see this? You know, in small cell cancer, the cells which are there, they are very fragile, right? The cells which are there, they are extremely fragile, right? So when there is a tumor, these cells will break. The cells will break when there is small cell cancer. When these cells break, their DNA gets released. DNA released, right? So when this DNA is released, it gets deposited in blood vessel wall. It gets deposited in blood vessel wall and it produces basophilic staining of the walls. Basophilic staining of the walls. Can you appreciate in this image here? Can I appreciate basophilic staining here? Can you appreciate this basophilic staining? That is what you call as a azopody effect. The cells are fragile. So what will happen? These cells will break, their DNA will come out. This DNA will get deposited in the wall of the blood vessel. DNA or nucleus is basophilic, so it will produce basophilic staining of the vessels. That is called as the Azzopardi effect. Right. Another thing, because students, what happens is there have been various theories which have been put forward, and they say this small cell cancer also has some neuroendocrine origin. That is why another thing which you will see is granular chromatin, which is called as the salt and pepper chromatin. I will be showing you images of this when I teach you carcinoid tumor in 5 minutes. So it is called as salt and pepper chromatin, correct? So that is important. So 5 important microscopic features for small cell lung cancer. 1. Small cells, scanty cytoplasm, hyperchromatic nuclei, areas of necrosis, nuclear molding, Azzopardi effect, correct? This is important for small cell lung cancer, right? Now, what are the immunohistochemical markers? Suppose I'm unable to identify that this is small cell cancer. Can you apply any immunohistochemical markers? Yes. The IHC markers which can be used for diagnosis, they were asked in AIMS exam twice or thrice, students. Remember, the IHC markers are neuron specific enolase, synaptophysin or chromogranin. NSC, synaptophysin or chromogranin. NSC, synaptophysin and chromogranin. These are the 3 markers which we use for any neuroendocrine tumor. And because the small cell cancer has been implicated, that this also has neuroendocrine origin, that is why these 3 markers can be used. In fact, remember students, some extra edge information, these 3 markers can be used for any of the neuroendocrine tumors, right? So the histopathology, the markers and electron microscopy apply for any of the neuroendocrine tumors. I'll just give you a list. Before that, I'll tell you what is the electron microscopy for small cell lung cancer. We see dense core neurosecretory granules. On electron microscopy, I see dense core neurosecretory granules for any neuroendocrine tumor, right? So I'm repeating once again, for any neuroendocrine tumor, 3 things. Histopathology will show salt and pepper chromatin. The electron microscopy will show dense core neurosecretory granules, and immunohistochemical markers are right. So these 3 things, that is the histopathology showing salt and pepper chromatin, the immunohistochemical markers like neuron specific enolase, synaptophysin, chromogranin, and the electron microscopy of dense core neurosecretory granules is present in neuroendocrine tumors. So here's some extra edge information for all of you for MCQ exams. This is some extra edge information. So that is the list of neuroendocrine tumors. It's an exhaustive and a big list, students. I'll just tell you those which are important for your exams, right? So one is we're just studying, that is small cell carcinoma of lung. Then we have carcinoid tumor. Then pheochromocytoma. Then we have paraganglioma and carotid body tumor. Correct? That is a list of some neuroendocrine tumors, right? So if the examiner asks you histopathology or markers for any of these, you know what to mark, correct? With this, this is also over. So the last type of lung cancer which we have is called as large cell lung cancer. It is called as large cell lung cancer, right? That's the last type of lung cancer which we have, large cell. Now, as the name suggests, students, what do you see? You see sheets of large, highly pleomorphic cells. Sheets of large, highly pleomorphic cells, right? They're quite large cells with prominent nuclei, hyperchromatic nucleus, right? This is usually centrally located, right? Then students, this is usually a diagnosis of exclusion. Remember this point. This large cell lung cancer is a diagnosis of exclusion. Why? What do you mean by diagnosis of exclusion? If you exclude all other kinds, the patient does not have squamous cell cancer, adenocarcinoma, small cell cancer, I come to a conclusion that the patient has large cell cancer because this is not positive for any of the particular markers and does not have a particular histopathology. For example, this image, students, can you appreciate these very, very large, highly pleomorphic cells, right? And it doesn't look like squamous cell cancer. Why? Because SCC will show keratin pearls and will be positive for P63, P40 or cytokeratin. That's not there. Adenocarcinoma, there is no glandular pattern which I see. Plus TTF1 and apsin A negative, not adenocarcinoma. Small cell cancer, you are not seeing any cells with salt and pepper chromatin. These cells are very, very large. They are not small cells. There is no nuclear molding. I come to a conclusion that this is not even small cell cancer. So what is this? This is large cell lung cancer. Large cell lung cancer. Correct? So this is about these 4 types of lung cancers: squamous cell, adeno, small cell and large cell, right? Now what I have done is, students, I have made a very, very nice table to give you a gist of whatever we have studied till now. This is an important table of how you will differentiate between all these lung cancers. So in this table, can you people see that the only cancer which is more common in females is adenocarcinoma, while the rest 3 are more common in males, right? So very, very important. Please remember, history of a woman, think about adenocarcinoma. Central located small cells, peripheral located large cells, right? So the large cell which we did here is peripheral as well as central, correct? Smoking associated squamous cell cancer, adenocarcinoma, I've already told you, non-smokers. Strongest association with cigarette smoking, small cell. Large cell is present in both smokers and non-smokers. Paraneoplastic syndrome associated with SCC is hypercalcemia. Why? Due to parathyroid hormone related peptide. Adenocarcinoma, migratory thrombophlebitis, I have told you. Small cell Cushing's SIADH, which is the most common paraneoplastic syndrome associated with small cell lung cancer, SIADH, right? Large cell cancer, the paraneoplastic syndrome is gynecomastia, right? Pathogenesis में important mutation for squamous cell P53, adeno KRAS EGFR ALK, all of you know. Small cell LMYC, large cell no particular mutation. Microscopically, keratin pearls and desmosomes for SCC, glands lined by pleomorphic cells adeno. Small cells, salt and pepper chromatin, nuclear molding, azopardy effect and necrosis are 5 histopathological features of small cell lung cancer. And large cells, you see large, highly pleomorphic cells, correct? Immunohistochemical markers, squamous cells, CK, P63, P40, you all know. Adeno, TTF1, napsin A. Small cell, NSC, chromogranin, synaptophysin, and large cell is a diagnosis of exclusion because it is none of the markers positive, correct? Very important table. You paste it in your room or this is an extra edge or high yield table. Put it in a separate copy because just before the exams, 1 week before the exam, you have to revise all these things, right? Very, very important table, correct? Now, students, how will a patient of lung cancer clinically present, right? Any of these, how will a patient clinically present? So, the most common symptom of lung cancer, the most common symptom which the patient presents is cough. That's the most common symptom. Patient can have dyspnea. Another common symptom is hemoptysis, right? Hemoptysis, correct? Remember students, lung cancer at the apex. If the lung cancer is present at the apex of the lung, what it does, it compresses the cervical sympathetic chain. It compresses the cervical sympathetic chain, and what it will produce, students, it produces something called as Horner's syndrome, right? And this lung cancer at the apex is also called as Pancoast tumor. This lung cancer at the apex called as Pancoast tumor, what it will do? It will compress the cervical sympathetic chain and produce Horner's syndrome. What are the symptoms of Horner's syndrome? For that, I have made a mnemonic that is Punjabi meal. The mnemonic is Punjabi meal. P for ptosis, M for meiosis, E for enophthalmos, A for anhidrosis, and L for loss of ciliospinal reflex, right? So this is the mnemonic for features of Horner's syndrome, the symptoms of Horner's syndrome, that is Punjabi meal, ptosis, meiosis, enophthalmos, anhidrosis, loss of ciliospinal reflex, right? Then lung cancer spread. The spread of lung cancer. Now it can spread where? It can spread directly to the recurrent laryngeal nerve. To the recurrent laryngeal nerve. And when it goes to the recurrent laryngeal nerve, it can produce hoarseness, right? What it produces? It produces hoarseness. Then this cancer can go to the lymph nodes. Which lymph nodes are commonly affected? That is the hilar lymph nodes. Then it can metastasize, right? It can metastasize. Which sites? Liver, brain, adrenal. Here I would like to tell you one very important point, students, that earlier Robbins, till the 2019 edition, what was there was the brain and the adrenal are very, very common sites, but 2020, the latest edition of Robbins says that liver is the most common site of metastasis of lung cancer, right? Now this, the tumor thing and the WHO classification, and the WHO keeps updating the data for all these tumors. So the latest data which has come up, which has been cited in the latest edition of Robbins, says that the most common site of lung cancer metastasis now is liver. It is neither lung, neither brain nor adrenal, but yes, brain and adrenal are also very commonly affected, right? This is where the lung cancer usually spreads, correct? So this is about the various types of lung cancers and their symptoms. How will the patient clinically present, right? Two other lung tumor, students, which are very important and you should know about them. One is called as the carcinoid tumor of lung. One is called as the carcinoid tumor of lung, right? So a carcinoid tumor, it is a neuroendocrine tumor. So which cell does it arise from? It arises from the Kulchitsky cells. It arises from the Kulchitsky cells, correct? Remember, only 10% of carcinoid tumors will show features of carcinoid syndrome. will show features of carcinoid syndrome. Only 10% of carcinoid tumors will show features of carcinoid syndrome. So how will a patient clinically present? What are the features of carcinoid syndrome, students? There can be flushing, sweating, diarrhea, right? Correct, students? Then students, what is important? Then students, the points which I have already discussed with all of you, what will you see on the histopathology of carcinoid tumor? Suppose that's the slide, what will you see? The cells are present in a rosette-like or nest-like pattern, right? So pattern which are separated by fibrovascular stroma. The cells are separated by some fibrous kind of stroma. There is a stroma around the cells, right? Then the cells have got something which is called as salt and pepper chromatin. I just told you some time back that all those neuroendocrine tumors have got salt and pepper chromatin. So cells have got salt and pepper chromatin. I'll just show you a picture, students, the real picture. Plus, students, I've already mentioned it to you that what is the immunohistochemical marker that you will use? The IHC markers for carcinoid tumors and for that matter any neuroendocrine tumor are NSE, synaptophysin, chromogranin, while the electron microscopy shows dense core neurosecretory granules, right? Now let us see an image. In this image, can you appreciate these nests of cells? This is one nest which is present. This is another nest which is present, right? All these nests of cells. And can you appreciate these cells? And these cells have got this stippled chromatin or salt and pepper chromatin. This chromatin is better visualized in this picture, students. It is better visualized in this picture. See these cells. Can you see? When you mix salt and pepper, you will see this appearance, a granular chromatin. Because of neuroendocrine granules, it is called as salt and pepper chromatin. Beautiful, right? And that's the fibrovascular stroma, fibromuscular stroma, which I was telling you. The cells in various patterns separated by this stroma. The cells have salt and pepper chromatin. Right. So this is another take home point. These images were given in AIIMS exam 2 years back, so they can be given again. Please remember these images, right? Based on the histopathological features, there can be two types of carcinoid. One can be a typical carcinoid and there can be a atypical carcinoid, right? What's a typical carcinoid tumor? What is a typical carcinoid, students? In a typical carcinoid, what happens? There is less than 2 mitosis per 10 high power field, whereas 2 to 10 mitosis per 10 high power field is present in atypical carcinoid. 2 to 10 mitosis per 10 high power field, right? There is less pleomorphism, more pleomorphism, correct? Then less necrosis, then there is more necrosis, right? These are the important points to differentiate a typical and an atypical carcinoid. Why will you want to report a atypical carcinoid? For just this thing that a better prognosis is that of typical carcinoid as compared to a atypical carcinoid, correct? So these the pictures I've already told you, correct? With this, students, I'm coming to the last kind of lung tumor, and that is called as malignant mesothelioma. This has become an examiner's favorite recently they have started asking a lot of questions on this tumor that is called as malignant mesothelioma. So I am marking this as very, very important, although this entire module is very important for all MCQ exams, right? Malignant mesothelioma. Whenever a pathologist hears or a clinician hears about malignant mesothelioma, what comes to my mind is asbestos exposure, right? So it is more specifically, so a very important risk factor for malignant mesothelioma is asbestosis, is asbestos exposure. Right now, asbestos exposure, a very important high yield point which I would like to give you here is that, for the development of malignant mesothelioma, a long exposure to asbestos is required. So the latent period for asbestos exposure is approximately 25 to 40 years. That means asbestosis, that means mesothelioma will develop if the asbestos exposure has been there for so long, that is 25 to 40 years, right? And asbestos is usually present in shipping industry, right? Shipping usme. That's why sometimes in a clinico-pathologic MCQ, you can be given a history that the patient works in a shipping industry. Patient works in a shipping industry, correct? So the latent period is 25 to 40 years, right? Now from asbestos, another tumor of lung which arises is lung adenocarcinoma. But the latent period there is approximately 10 to 30 years. It is not 25 to 40 years. It requires a lesser latent period to develop adenocarcinoma rather than a malignant mesothelioma, right? What are the other things in the pathogenesis? The genetics can be, as with other things, there can be P53 mutation which can be there. SV40 virus has also been implicated sometimes in the development of this tumor, correct? Then students, when I tell you about the microscopy, what will you see on microscopy? There are three kinds of cells which can be seen. There can be spindle cells, or I can see epithelioid cells, or there can be sarcomatoid pattern. By now, you all know, I hope you all know how to identify and differentiate a spindle cell from an epithelioid cell on histopathology. Spindle cell is like this with pointed ends. Epithelioid cell has a little blunt ends, right? Very minor difference. But yes, you can identify these types of cells, spindle cells and epithelioid cells. So these three patterns can be seen on the slide, right? Then students, one very important thing is the immunohistochemical marker for diagnosis of this. The best marker which is used for the diagnosis of malignant mesothelioma is calretinin. The cells are calretinin positive. That is the best marker for diagnosis, correct? So this is all about malignant mesothelioma, right? So what is the immunohistochemical marker for diagnosis? The cells are calretinin positive, right? Then students, last point which is also asked these days is the electron microscopy. On electron microscopy, here you see long, slender microvilli or tonofilaments. What I see on microscopy are long, slender microvilli or tonofilaments. Long, slender microvilli, correct? That is what I see. Normally they are short. You will see here long, slender microvilli. For example, let us see this picture, students. For example, let us see this picture. Can you appreciate these long microvilli which are there? So this is basically malignant mesothelioma. Correct? So I hope this much is clear to all of you. Now, what additional points, some extra edge information I would like to give you here is that from asbestos exposure, two types of cancers can arise. One, lung adenocarcinoma, another malignant mesothelioma. How will you differentiate malignant mesothelioma from adenocarcinoma of lung and lung adenocarcinoma? Firstly, I told you asbestos exposure. Asbestos exposure. In mesothelioma, it requires approximately 25 to 40 years, whereas for lung cancer development, it is 10 to 30 years. Correct? Mesothelioma is positive for two markers, students. Calretinine positive, I've already told you. Lung adenocarcinoma is negative. It is vimentin positive, whereas lung adenocarcinoma is negative. Then you all know TTF1, that is negative in mesothelioma, positive in adenocarcinoma. Then students, we have electron microscopy. I told you mesothelioma will show long, slender microvilli or tonofilaments, whereas short, plump villi are seen in adenocarcinoma. Short, plump villi are seen in adenocarcinoma. This is some extra edge information which you need to know, right? So with this, students, we finish off with all the different types of lung tumors. I hope this is very, very clear to all of you. This is in detail and you don't need anything else except for this. All the images which I have shown except for pulmonary hematoma can be asked in the MCQ exams, right? Now let us discuss a few MCQs which can be asked. Few MCQs, the kind of MCQs which can be asked. 56-year-old chronic smoker presents with cough and hemoptysis. Mass is resected. What is the possible marker, right? Now, a smoker with cough and hemoptysis and a male, you have resected the mass. What is the possible marker? What are the possibilities? A patient can have either squamous cell cancer or small cell lung cancer, right? Cytokeratin. Yes, that's the marker for squamous cell cancer. That can be the answer. Vimentin is an epithelial marker. Not the answer. Epithelial membrane antigen is a marker for tumors like meningioma. That's not the answer. Napsin is a marker for adenocarcinoma. Now, this cannot be adenocarcinoma. Why? Because the patient is a smoker. So, what's the answer? Cytokeratin. Correct? So, you have applied all the information to come to this diagnosis. Next, 60-year-old man, grayish-white tumor located at the central bronchus causing obstruction and bronchiectasis. Biopsy will show. Now, very interesting question, student. An old man with a tumor in the central bronchus which can cause obstruction and bronchiectasis. Now, it can either be again a squamous cell cancer or it can be a small cell cancer. Any of these it can be, right? So, biopsy will show spindle cells. No. Do you see spindle cells in any of the lung tumors? Spindle cells? Yes, I see in malignant mesothelioma. That's not the answer. Contains all three germ layers. Which tumor contains all three germ layers? Just general pathology. Teratoma? Teratoma is not present in the lung. That's not the answer. Abundant osteoid matrix formation. It is a characteristic feature of osteosarcoma. This is not osteosarcoma. Last option. Small round cells, hyperchromatic nuclei, nuclear molding. Features of small cell lung cancer. That's why this is the answer. Small round cells with hyperchromatic nuclei and nuclear molding. Correct? Next, a 35-year-old woman presents with coughing, dyspnea, flushing, diarrhea for a month. Histopathology of mass is given below. Mitosis was 5 per high power field and is chromogranin positive. What is the diagnosis? Very nice question, students. This question was asked in AIMS exam 3 years back. Direct question with the image. Now, a woman, carcinoid tumor is more common in women. With a history, see, the history is that of carcinoid syndrome, that is flushing, diarrhea, correct? Histopathology, okay, I'll come to histopathology later on. Suppose you don't know how to see the histopathology. Chromogranin positive is another clue. Chromogranin positive means it can be either carcinoid tumor or it can be a small cell carcinoma of lung, right? What is the diagnosis? So in this image, can you people appreciate a few cells? In this image, can you people appreciate a cells which have salt and pepper chromatin small cells, right? So what is this? This is a carcinoid tumor of the lung, and because they have given that mitosis is more than 5, because they have given that the mitosis is more than 10, is 5 per high power field, right? I told you less than 2 is what? Typical carcinoid. More than 2, between 2 to 10 is atypical carcinoid. That is why the answer here is atypical carcinoid. It cannot be small cell cancer because, women history, no smoking history they have given, flushing diarrhea history, all these points towards a diagnosis of carcinoid tumor. Correct? Next. Lymphoma-like picture in lung cancer is seen in which subtype, students? Lymphoma-like picture with large cells. Usually it looks like diffuse large B-cell lymphoma is seen in large cell carcinoma of lung, right? It's a feature of large cell carcinoma of lung. Next. Incorrect statement about small cell lung cancer. Which statement is incorrect? Let's see. Not associated with cigarette smoking. Yes, that's incorrect because it is strongest association with cigarette smoking. Surgical resection alone is a treatment of steroids. That is also an incorrect statement. Why? Because I told you this tumor is chemosensitive. Surgery though we don't do because usually the tumor has metastasized when it comes to us. Associated with paraneoplastic syndrome, that's a correct statement. Contains neurosecretory granules. Yes. Most patients have distant metastasis at the time of diagnosis. Correct. So which two statements are incorrect? Not associated with smoking and surgical resection is a treatment of choice, right? So students, these are the kinds of questions which can be asked in your MCQ exams. A very, very important module and a very, very important system where you've just finished, that is lung, right? Thank you so much, students, and all the best.